Good afternoon.
Good afternoon.
Thank you for joining us. I do have a disclaimer. I'm waiting for people to jump on because we are live on Facebook. And if you want to ask questions at the end, I'll probably stop the live so that we can have more of a dialogue.
So if you're on Facebook, I'll join in on Facebook.
No, I'd rather this actually, because that way I can talk to you afterwards.
Okay.
And so we'll stop the recording and before the questions so that we can have more of a private conversation if anybody has questions.
Okay.
All right.
Thank you.
No problem. Thank you for joining us. All right. Well, good afternoon. It's 12:01, so we're going to get started. I thank you guys for joining us this afternoon. Today, we're going to talk about something near and dear to my heart, which is pediatrics. And I am a physical therapist. I have treated in my lifetime, I guess, mostly children that have severe impairment, that are children that have a varied amount of diagnoses, mostly cerebral palsy, but many children with brain injury and that even stemming from a coma, from different very serious injuries, and to working with children that are more active, that are ambulatory, and that have physical therapy. I currently teach at LIU Brooklyn, and I am here to share a little overview about cerebral palsy, Down syndrome, and autism. I do have some information on intellectual disabilities if we get to it, but this is a loaded lecture. I tried to kind of condense it so that we can kind of get to have some time for questions and answers, okay? If you have any questions, feel free to throw them in the chat, and at the end, we'll definitely talk about them as a group and for personal and in respect for HIPAA, if there's any parents that may have children with any of these diagnoses, I would prefer to stop the recording and just have an open dialogue at the end. All right, so told you a little bit about who I am. So today we're going to focus on reviewing the prevalence, the etiology, and prognosis of children with cerebral palsy, Down syndrome, and autism. I'm going to talk briefly about treatment because the treatment options are so vast, but I will kind of give a little bit of an overview for each diagnosis so we can talk about that. And so prevalence is the incidence, how often and common that you may see a child with this diagnosis. Etiology is what some of the risk factors or some of the research evidence proven causes may be. And then prognosis is life expectancy. All right, so first we're going to talk about CP. Cerebral palsy is a non-progressive neuromuscular disorder. Typically, this occurs either during, it can occur before, during, or after birth. It is basically a brain injury that may have happened in utero for various reasons. We'll talk about some of the there's some genetic, there's some infections that can lead to some kind of impairment on the brain or some kind of hypoxic event, which means there's a lack of oxygen to the brain. So that could happen inside while the baby is perinatal, before the birth, during, and prenatal, and then perinatal is during the actual birth, that there are things that can happen. It's a very traumatic experience to go from a nice, safe, cocooned environment for an infant or fetus, and then they have to pass through the vaginal canal and come out to the outside world. So there's a lot that happens in that process, and so things can occur. It is more rare for things to happen during that during delivery, but it can happen, and so that's that may be when a child may have this loss of oxygen to the brain. And then after birth, seizures, things that could happen of unknown etiology, but these things do happen. I do want to say, as we talk about some of the risk factors as we get into it, I don't want to harp on that, because the way I love these children, the way that the families love these children, these are children that are special gifts wrapped in unique packages. So I don't want anyone listening to this lecture that may be a parent or a family member of a child with cerebral palsy to harp on the things that may have caused or what have happened. I think it's more important for us to focus, and we'll talk about that on where we are and the things that we can do to help improve the quality of life of our these special children. So I don't want to harp on those things, but I will give you a little bit of a background. Okay, and again, so cerebral palsy is typically an umbrella term. So I did talk about the many things that can happen prenatally, perinatally, and postnatally. But the point is that you guys should know that it does cover kind of the gamut of what can be wrong in terms of the brain injury, the part of the brain that may be impaired, or what can be manifesting in some symptoms. And we'll talk about that. But typically, you get this diagnosis of a multiple kind of comorbidity, multiple disabilities that affect neuromotor impairment by the age of 2. That's typically when a child will get a diagnosis of cerebral palsy. And so prior to 2, it's usually the parents that pick up on something that is not typical, especially if you are this is not your first child and you notice there's some things that your new child is not doing as compared to your other the siblings. You may ask questions to your pediatric. So I just want to just remind anyone, if you're ever seeing anything as a parent or a caregiver to a child and you see something that you feel is atypical, trust that instinct. Go see a medical provider and get more information. um, and so we'll talk about cerebral palsy and how we can kind of classify the different levels of impairment or different levels of function in this population. And that way, me or us as physical therapists, we understand where they are in their functional capabilities. All right, so this is the second most common neurological impairment. The first is mental retardation, but the incidence of cerebral palsy is 1.5 in 4 cases per every 1,000 live births. And this is estimated from the CDC. Um, It is the most common motor disability in childhood, and prevalence has increased due to increased preventive care. So, and I say that because years prior, there was not as successful NICU treatments and uh, prenatal and success rates of parents having children prematurely. Now that we are able and medically savvy enough to handle an early birth, even as early as 28 weeks to gestation, there are some challenges that come with prematurity. And so, because we're able to handle prematurity in a better way, that has led to more of a diagnosis of cerebral palsy because it is more likely that there will be some kind of impairment that occurs because of the prematurity. So you're seeing improved survival rates with very low birth weight infants, that's premature children. You're seeing improved obstetrics, improved neonatal care, and treatment of maternal fetal RH factor incompatibility. So that is one of the common causes or risk factors for cerebral palsy. And also, we're seeing a lot more multiple birth pregnancies due to in vitro fertilization. And so it is not uncommon for you have multiple births that maybe one of the children may not have received as much nutrients because of the crowdedness in the uterus. Okay, so causes, like I said, we're not going to harp too much on these, but they're unknown. It could be multifactorial, prenatal, perinatal, postnatal conditions resulting in cerebral anoxia, loss of oxygen, cerebral hemorrhage, bleeding on the brain, and other damage to the brain. And that's typically usually the cause of something that may have an effect on the formation, normal development of the brain. So again, cerebral palsy is typically, it is a brain injury. All right, so let's talk more about some of the evidence and causes. So normal birth weight infants, 80% are caused by prenatal factors, maybe lack of care, inadequate care, could be environmental challenges. 20% are as a result of perinatal during the birth and postnatal. And typically, the injury will occur in those first 4 weeks after birth. Low birth weight infants with CP, uncertain when brain damage occurs. We don't know because there's so many challenges with prematurity. Has to do, you have respiratory challenges, and that may be the cause of the lack of oxygen to the brain. You have a lot of GI issues with premature infants or children with low birth weight. So we're really not sure with this population when the brain damage does occur. In term infants, the majority of cases are due to prenatal unknown causes. And like I said, there's many other factors that include anoxia and hemorrhage in the brain. So I'm going to go move on because there's so much more to talk about. Oh. All right, so like I said, I do want to give an overview about some of the risk factors related to prenatal, perinatal, and postnatal. So when talking about what the evidence has shown for prenatal, there are infections that are quite common. So you rubella, cytomegalovirus, herpes simplex, and toxoplasmosis. So toxoplasmosis is a disease that results from infection from a very common bacteria parasite, and that is the Toxoplasma gondii parasite, and it's one of the world's most common parasites. And so this infection usually occurs by eating undercooked contaminated meat and exposure from either infected cat feces or mother to child transmission during the pregnancy. So that is one of the most common risk factors to prenatal. There's maternal diabetes, Rh incompatibility. So Rh is a factor in the blood. And so it's a condition that occurs during pregnancy if a woman has Rh negative blood and her baby has Rh positive blood. So that incompatibility can cause a problem. There's also maternal malnutrition, maternal thyroid disorders, mother seizures can be an effect on, can cause an effect on the child and can lead to brain injury. Radiation, abnormal placenta attachment. Even with my second born, I had abnormal placement of the, I can't think of the term right now, of the attachment of the umbilical cord to the placenta. So I had to have regular, actually increased visits with my OBGYN to make sure the growth was up to date and on schedule. And so that's something that if there is some kind of abnormal placenta attachment and you're not having adequate checkups, that can cause decreased growth and lead to prematurity. There's also congenital anomalies of the brain and coagulation factor abnormalities. And these are some other risk factors. I'm not going to go into detail, but it's just good for you to be aware that there's some other things that that can cause a brain injury. And so I list factor 5 lead mutation and autophospholipid antibodies. There's evidence that shows that this can cause in a lack of protein binding. And specific to factor 5, it's a mutation of one of the clotting factors in the blood. And for antiphospholipid antibodies, it's a group of immune proteins that the body mistakenly produces against itself. And so if you imagine if your body's attacking itself while you're pregnant, you can see how that can cause a lack of nutrition and development to a growing baby. So you just want to make sure when you're pregnant to get to see your OB on a regular basis, to continue to take your prenatals. And if you're ever in doubt or concerned, make sure you go ahead and check with your doctor. So these are some of the risk factors perinatally. So we talked about during that birth process. And so when you think of these aspects, we're looking at prematurity, number one. You know, for some reason the water may break a couple of weeks early. You may see obstetric complications, mechanical birth trauma. You don't really see too much of use of forceps, but that could be necessary to help pull the baby out of the vaginal canal. Breech delivery, multiple births, prolapse umbilical cord, and abruptio placenta are very serious. So that is when there is some kind of abruption of the umbilical cord, or you'll see a lot of the times with some children that may have a breech birth, the umbilical cord comes around the fetus's neck, and then the child is of course at risk of losing oxygen. So those are all very serious risk factors. And some others, I may have heard of the APGAR test, which is a test that the baby undergoes as soon as the child is delivered. You may have heard, if you don't have any children, when the baby gets smacked, they smack the baby's butt to hear a cry. They're looking at the face and looking at the skin tone of the child, and there's a grade that is given. So they do it more than once if there is an abnormal score. Anything less than 4 at 5 minutes is of a risk factor concern, okay? And a small gestational age is just the child is underweight, and low birth weight clearly is a concern for a child. Okay, so these are the things we're looking at post-birth, postnatally, after that immediate period of birth. Neonatal infection, meningitis, encephalitis. This is a concern for everyone, right? But these are things that babies are, of course, more fragile, less of an immune system developed. So if there's a neonatal infection, it can really take more of a hold on the infant. Environmental toxins, trauma, uh, carnivorous, which is when you have an over amount of it can lead to jaundice is when you have it is a rare kind of preventable brain damage, but it occurs with newborns with jaundice. So you've heard of jaundice is when you see that yellow pigmentation in the skin. So if that is not managed, you will have this type of brain damage, which is called kernis. I'm always pronouncing this wrong, kernivorous. So, and other things that could be a risk factor postnatally or brain tumors. You can have anoxia, near drowning. A child can be diagnosed with cerebral palsy later in life as a result of a brain injury. Shaken baby is one that causes a brain injury, and that's a traumatic brain injury. But as a child will grow from that phase of the trauma, they will have cerebral palsy as a diagnosis for the remainder of their life. And then there's also strokes. Infants can have strokes. It is rare, but it can happen as a result of many different things. And neonatal hypoglycemia has to do with lack of glucose levels, I think less than 30 um, milligrams per liter, and usually they're monitoring this in the first 24 hours of life, so they can usually pick up on that pretty early in the hospital. But it is a very common metabolic problem in newborns. And then acidosis, which is the process causing increased acidity in the blood, and so that can also lead to a brain injury and lead to cerebral palsy. Okay, so now we're going to get into some more of the science of it. I don't want to spend too much time, but this is kind of what I do. So I'll talk a little bit about pathogenesis. And so there is no consistent or uniform pathology, but these are the top three ways that the brain may have the insult. So there may be a hemorrhage, there may be a hypoxic ischemic injury or encephalopathy, or thirdly, you may just have a central nervous system malfunction, and that can just mean there is a change in the brain structure. So when thinking about a hemorrhage, I'm talking a lot in strokes. Specifically, I'm talking about strokes, and it's the most common form of brain injury in the premature infant. The incidence has recently moved from 49% in very low birth weight infants to 20% in the same population. And so this can be a result of the difficult delivery, the breech presentation, or trauma, where a blood vessel may have burst and now you're having bleeding on the brain, right? And so this can develop very quickly, or it can be delayed. So you really have to, if there's any signs early in birth, your pediatrician may pick up on it. And then a lot of the times you just won't know, and so this is one of the causes. Hypoxic, again, is the lack of oxygen. So there's three possible underlying causes. It's usually a decreased perfusion resulting in systemic hypotension and poor auto regulation of the cerebral blood flow. So there's some kind of lack of auto regulation. The blood vessels are not getting where they need to go for one reason or another, and so one area of the brain is not getting the actual blood that it's supposed to be getting. There could be a clot, so that's another of the major causes, right? Three possible causes I talked about. So emboli, which is blocking the distal perfusion, and then and clot formation is the third, but the emboli is something that can be traveling through and causes the distal perfusion, and the clot formation can cause the hypercoagulative state. So the emboli is a clot, but when it leads to the third cause, you're having a hypocoagulative state. So one area will have too much blood, and like I said, there's area that will have not have enough, and then the area that has too much blood can drown the tissue in that area of the brain, and now you have basically malformation of the central nervous system, which is the third a pathology that is common with children with CP. And so, but there's many other reasons why you may have central nervous system malformation. It could be genetics. It can be some kind of infection. We talked about acidosis, hypoxic ischemia, and maybe a prenatal stroke. The mother could have a stroke, which would lead to the baby losing oxygen as well. So there's many different things that could lead to CP, But this is kind of a quick overview of the pathogenesis. If you have any questions about this, I'm happy to talk about it in detail. But again, this is very, very challenging to understand for a layperson. So motor types. Now we're going to get into kind of the clinical picture of cerebral palsy. So there's different motor types that you may see in a child with cerebral palsy. The most common are spastic, dystonic, which may include rigidity, and athetosis, which is kind of a slow writhing movement when a child is attempting to reach a toy or participate in activity. Ataxia is typically defined by discoordination. I talked about the athetoid, which is the writhing, and then you'll see mix, which may include a high tone, which is typically someone that is a little bit more rigid. And then you may see low tone, which is, if you see in the picture here, the image, the baby on the right who has the head lag, he has low tone. He doesn't have the control to lift his chin or tuck his chin when that mom is trying to bring him to sit. Okay, and so in the first picture here, this is a picture of a child with spastic diplegia. So her lower extremities are more involved, and you can see that they're kind of pointing inward. The second child has athetoid CP. So there is a bit of a asymmetry that you'll see in athetosis. So she has one arm out, other arm closed in, and you can see her arms are very stiff, but she is attempting to walk. So when you have that athetosis, there's usually accessory movements that come along with the voluntary control. And this little guy, I would say, is a combination of low tone and ataxia. So he is hanging into that wall because when he lets go and he tries to take steps, he's uncoordinated. He's not comfortable in space. He needs the wall to keep himself sturdy before he actually takes some of those steps. And we'll talk a little bit about that as we go on. All right, so there's a distribution of limb involvement. I talked briefly about the little girl on the left in that first picture, in that first slide, where she had diplegia, which basically means two. So the way we define the movement patterns or the effects of the motor types, we define them based on what limbs are involved. So monoplegia means one limb, right? It takes you back to Latin in high school. Hemiplegia is one side, right? So mono is just one limb, maybe one hand, one leg out of all three extremities. Hemi is one whole side. Diplegia is two limbs. Typically, the top limbs are not as affected as the bottom. So very common. You don't really see as often triplegia, which is three limbs. But quadriplegia, you'll definitely see, and that's when all four limbs are affected. To give you a little information about the different types of CP and kind of where the numbers are in terms of prognosis, someone who has hemiplegia, they're slightly more frequently impaired on the right. They seldom are diagnosed at birth. So that's the group that is really not, the impairment is a little less obvious. So they're usually not diagnosed early in the hospital, maybe later in time. Their motor development is slightly delayed, but typically, you may see this population learn how to walk and to do some other common pediatric task because it's only the one side. But 35 to 43% of hemiplegic children with CP that have hemiplegia have seizures. So this is another thing that kind of on top of the motor disorder, there's multiple comorbidities, and we'll talk a little bit about that as well. So when talking about the children that have spastic diplegia, it's the most common form of CP with the legs involved, as that little girl that I showed you guys. And 2/3 of these cases are caused by prematurity. The prognosis for ambulation is fairly good for just the children that have the legs involved with the diplegia, mainly because they have good control of their upper extremities and they're able to use an assistive device to get around a little easier. And so typically in terms of the numbers, only 2% of children with spastic diplegia are non-ambulatory, meaning they do not walk. And their intellectual and speech capabilities are within functional limits and or only slightly impaired. And this again would be correlated to where the brain damage has occurred back either prenatal, peri, or postnatal. So that the brain is always kind of, I'm not going to go into neuroplasticity and neuroscience, but the brain is what basically allows us to function because we get stimuli and we get signals from our brain. It tells our muscles and body what to do. And if there is some disconnectivity in the brain, our muscles and our movements are affected. And lastly, for a child with spastic quadriplegia, it is often the cerebral palsy type that has the most severe brain damage, leading to multiple impairments. And that includes vision, hearing, and cognitive capabilities. Because typically, when you're thinking of a child with quadriplegia, there is periventricular leukomalacia, where there's a lot of plaques because of the brain damage or the loss of oxygen that occurred that have basically been developed in the brain, and those plaques limit the ability of the brain to recover so that they can gain more function. And since it happens at such an early age, the motor maps and the motor planning that occurs as we develop over time, we create cortical maps, and that's something that we can tap into. If an adult has a stroke, they can tap back into those maps because they're already preformed. The challenge with children with CP, the injury happens so early in life, those maps, those plannings, those plans in the brain have not yet been established. So it just makes it harder. It's a huge deficit to overcome. All right, so let's go on. All right, so back in the olden days when I was actually, well, it's not that old, but when I was finishing school in 2006, most of the classifications were starting to be developed by Palisano. However, we still use mild, moderate, severe when we talked about the type of CP someone had, right? And that can be a bit ambiguous because it depends on what you've been exposed to. But this was a healthy way for therapists to talk one amongst each other, let each other know. You would classify them if they were hemiplegia, diplegia, or spastic quad, but you would say mild, moderate, severe based on the level of functioning and the assistive devices that you wanted to help prescribe for the child. Now we use the gross motor classification system, which is great. So the gross motor classification system is a 5-tier system. I'll take you there. And so this is great because it allows the medical community to share information about the population that we serve by basically giving a clear cut idea of what the child is doing currently in their everyday motor capabilities. So level one is a child that walks without restriction. Their limitations are very limited. I mean, there's not as many limitations. You may see some challenges in balance and coordination, but as you see in the schematic, a child with level one is able to ambulate and able to carry something up the stairs. When you go to level two, a child is requires the use of a handrail and maybe assistive device to walk around. When we get to level three, we're talking about children that walk with assistive devices, unable to go up and down stairs typically, but and they may use a wheelchair for community ambulation. Level four, as we grow in impairment level, there are many self mobility limitations, but a child in level four may be able to use a weight supportive device to take some steps and a gait trainer, or they may be driving a power wheelchair to navigate their environment. And level five is the most involved. And these children usually are heavily relying on assistive technology. And that could mean switch activated toys. It may mean using a communication device so that they can engage with the population around them. I hate to say that the functional limitation does not always correlate to cognitive impairment. So I want to be clear: a child may be in level five, unable to ambulate or unable to keep their head up for a large period of time without being reclined so they can relax their neck muscles or what have you. But cognitively, they are taking in everything you're saying to them. They are communicating in the way they know how. And it's up to us as the adults and the caregivers to figure out a way for us to understand and engage with all of the children that we're talking about today. All right, so now let's go into a clinical picture about with children with CP. So um, I got a lot of this from a systematic review Novak put out in 2016, and Boyd and her colleagues in 2017 are putting together a basically predict CP model. They're getting a lot of data and about children with cerebral palsy, and really are going to follow them throughout their lifespan so that we can really start putting some pieces together about what is helpful, what is not. And so what we do know is that there's motor impairments, right? They have impacts that are related to growth and maturation. And that includes development of muscle tone, Also body composition, that is part of my research. I'm not going to bore you with that, but learning a lot about how children with CP have shorter stature, decreased bone density, because of maybe the lack of engagement in the typical activities, lack of standing, lack of the changes in nutrition because of the muscle tone. Spasticity is when the muscle is active, when abnormally active, when you're at rest, right? So that's almost if me and my wrist going up into extension, but I'm not telling my wrist to move. It's just a movement that occurs when I try to move my shoulder. And that's an example of spasticity. So a lot of the movement, muscle tone and movements that happen are not voluntary in this population, which can lead to an increased energy expenditure in this population. And they're burning calories a lot more than they're putting in. So you see a lot of challenges with body composition and nutrition in this population. But back to motor impairments, you're looking at decreased postural reactions, persistent of primitive reflexes. So there's reflexes that are normal in infants. One example would be when we call it a symmetrical neck tonic reflex. So when the neck goes to one side, there is a normal period of development where one arm will go into extension and one arm will be flexed, and that is like fencer position. After about 6 months, that should totally be gone. And so if you're seeing that later in a child's development, that's an abnormal, persistent primitive reflex. And so that's something that you will see in a growing child with cerebral palsy. You'll have delayed motor development. You'll have some abnormal motor performance. And with that, I'm talking about lack of force production, or when you're trying to voluntarily move one muscle, the joint may co-contract, the muscles around the joint co-contract. So there's a lack of actual movement that occurs, decreased speed of movement. There goes the co-contraction, and delayed movement onset. And so back to that article I was telling you about. So when you want to just get an idea of the multiple comorbidities in children with CP, this Novak looked at children with CP at the age of 5. And of the group that she looked at, 3 out of 4 had pain. So this is significant because a lot of the times we're talking about children that may have some communication impairment. And so we have to, as the caregiver, really try to understand what's happening with these children, because they may not be able to communicate them as effectively as another child typical that is developing typically. So 3 out of 4 have pain. That was significant to me. 1 in 2 had an intellectual disability. 1 in 3 was not walking. 1 in 3 by the age of 5 had a hip replacement. And so we'll talk a little bit about that. 1 in 4 could not talk. 1 in 15 were tube fed, meaning they're getting their nutrients either through an NG tube, which goes through the nose, or a G tube that goes through into their stomach, so directly into the stomach. And usually that happens because there's a lack of oral motor control and the inability to swallow safely. So in order to get the nutrients in, a G tube may be put in. So 1 in 15 were tube fed, 1 in 10 were blind, and 1 in 25 were deaf. So you see the level, and there were many more areas that she talked about in that article. For example, 1 in 4 had a behavior disorder. Even out of this group, 1 in 5 had a sleep disorder. So there's a lot of different things that our children with cerebral palsy are managing, and it's important for us to really have an understanding of that. Okay, so this is just more information about what children with cerebral palsy have in terms of comorbidities. And I talked about the poor oral motor control, sensory impairment, seizure disorders, mental retardation, which is the #1 common neurological dysfunction in children, period. 50 to 70% have cognitive impairment with CP. And we'll talk a little bit about communication when we get to autism, but you'll see a lot of central language dysfunction when you talk about vision, cortical visual impairment, and hearing loss or impairment is quite common. We talked a bit about musculoskeletal impairments as well. All right, so deformities. Because of the abnormal muscle control, I talked about athetosis and asymmetries and primitive reflexes and things of that nature. Because of the abnormal movement pattern, it is very common for children to develop over time deformities. And it is our job as therapists and your medical providers to really reduce the amount of deformity that develops. And so that's why we talk about bracing, we talk about adaptive positioning, standing, using AFOs, braces for the feet, maybe a spinal jacket if a child is low tone, meaning they can't hold their trunk against gravity. We may encourage the family or the physicians and the rehab team make us encourage the family to consider a scoliosis jacket to prevent the deformity in the spine as they age. With knee deformity, if a child is ambulatory and they have spasticity and they're going in a certain pattern, maybe rolling their toes in or rolling their hips in and walking on the inside of their feet, knees will start to rub together. There's some deformities that can develop at the hip. And it's really not uncommon to have a child have a hip subluxation where the hip kind of translates out of the joint, either due to a abnormal movement pattern or lack of ambulation as well. So those are things just to keep in mind. Okay, so medical management. Medical management is so important for a child with CP, regardless of the level of impairment, because if there is spasticity or seizures and other things like that, you're going to need your physician and your neurologist to give you medications or the child medications to help allow the child to engage in their everyday without uncontrollable seizures, right? Or without being uncomfortable. If 3 out of 4 children have pain at the age of 5 with CP, we need to see how we can help as a team to reduce that. And so that may include the use of spasticity medications. It may include the use of single event multi-level surgeries, which are quite common in children with spastic quadriplegia. And so that's when they will opt to do many muscle lengthenings, many, if there's an orthopedic surgery where they're needing to do any osteotomies or cutting of the bone to reframe the hip structure so that the child can comfortably stand or comfortably walk, they usually opt to do that at one time, and that's called a single event multi-level surgery. There's other surgeries, neurosurgical intervention, which is mostly common for children that are maybe have a spastic diplegia, that only the lower extremities are involved, and that procedure is called a dorsal rhizotomy. I would encourage anybody interested in learning more to really research that and to talk with their physician. I'm not going to go into detail about that, but it is a procedure where the dorsal roots of the spine are basically nicked, so that abnormal response to the muscles. I talked about the brain giving abnormal responses to cause spasticity. That happens in the spine for spasticity in a child with spastic diplegia. And so it is a long surgery, but there is some success with children that have spastic diplegia. Orthopedic surgery, I already talked a little bit about muscle lengthenings. You may have osteotomy and things of that nature. It all depends on what the child needs at that time. And then orthotic intervention. The goals of orthotics are to maintain flexibility, support and stabilize a joint, and improve alignment. That's where you'll definitely see the physical therapy kind of putting their 2 cents in, because we work with the child on a regular basis and we collaborate with the physician or the physiatrist about what this child needs, especially if they're coming out of surgery, or especially if we're trying to prevent or hold off on surgery till they get a little older. So we try to really manage with orthotics. So prognosis for CP is good news, normal lifespan. Okay, so like I said, let's focus on the positives. When we have children wrapped in unique packages and special packages, we really want to improve their quality of life. They're going to have normal lifespan. So let's do as much as we can to increase their ability to communicate, increase their ability to grow with least deformities, increase their joy and their engagement with their peers. Okay, so it's super important for the therapist to really have a family-centered care approach, for us to focus on trying to figure out what that child would like to engage in, what's age appropriate, so that they can ride a bike with their sibling, or they can go to the playground and engage with children their age. And so some of the common causes of death in CP are infection, aspiration, respiratory compromise, and heart disease. And so those are things that may happen at end stage of life. And because of, let's say, if a child is, or a young adult with CP, or an adult with CP has is still G-tube fed, there may be some challenges there with aspiration if something occurs or things like that. But typically normal lifespan for mild to moderate. Predictors for ambulation. It all depends on their motor milestone, sorry, right? So if a child is starting to make progress later in life towards getting on their knees or trying to pull to stand, even if it doesn't happen at the typical age of 1, it happens at 4 or 5. Then you're looking at, oh, this child may learn to walk. But typically, based on the literature, um, a child, if they're not reaching that ambulation milestone by 8 years old, typically at that point, it is not necessarily one of our major goals. Our major goals is to improve their ability to engage or interact, whether they use a power wheelchair, whether they use a communication device. And so I'm not saying it can't happen after 8, but what the evidence shows is that by the time of 8 years old, usually a child with CP has reached that ambulation milestone if they're going to hit it at all. Okay, so I do have a little video, but you know what? I'm going to save all the videos at the end because we are already at 12:40, and so I have two more diagnoses to talk about. Any questions about cerebral palsy before we move on? Okay, so the rehab considerations will be similar throughout what we're going to talk about. But our goals as a physical therapist, my goal is to maximize their function, increase variety of movements, prevent secondary conditions, especially orthopedic deformity, tenets of motor control and learning, apply task-specific training, practice, and neuroplasticity also apply. I talked briefly about that. What we know about the brain is 20 years in the past 20 years is amazing. We know so much more about how the brain can kind of heal itself in a sense, or connect those cortical maps. And there's changes if we focus on some specific task, specific training, or we talk about environmental enrichment and all of that. But again, it's harder for a child with severe brain injury because those motor maps have not been developed. But these tenets apply. PT should be fun and interactive. Anybody who knows me knows that I love playing with my kiddos, especially when I worked at the school. It should be family centered. The parents know the child the best. Any rehab specialist, physician, if you do not consider what the family can do or what they believe about their child and how you communicate with them, it's not going to be a smooth process. So it's very important to have family-centered care, and that'll be across the board with everyone here. School-age children, you need to include the teachers in the program, and as the child grows, their rehab needs change, and we talk about that across the lifespan. So now let's talk about Downs. I love my little Downs, baby. Oh my goodness. So Down syndrome is a chromosomal disorder that results in 47 chromosomes instead of 46. So basically you'll have an extra chromosome, and that is the 21st pair. There'll be an extra. So that's why it's called trisomy 21. And so when talking about Down syndrome, it is the most common cause of intellectual disability. It occurs in approximately 1 in every 800 live births. It was first recognized by John Landon Down in 1866, hence the name Down syndrome. And so typically, you will know if there was any kind of genetic testing that the child will be born with Down syndrome. Now, I know there are some instances where a parent may decide not to have that testing, and so then you will find out at birth. But typically, most parents that are having a child with Down syndrome will know, and they can prepare for some of the challenges or some of the things that may occur depending on the child's status when they're born. So prior to or at conception, there are 3 types. There's a trisomy 21, which is non-destruction, which is caused by faulty cell division that results in the baby having that 3rd chromosome. There's translocation, which accounts in only 3 to 4% of cases. And so basically a part of chromosome 21 breaks off during cell division and attaches to another chromosome. So it's a little bit different there. It's an extra piece of a chromosome. And mosaicism occurs when non-destruction of chromosome 21 takes place in one of the initial cell divisions after fertilization. So when this happens, there's a mixture of 2 types of cells, some containing 46 chromosomes and some with 47. Okay, and so this occurs in only 1 to 2% of all cases of Down. So just for your knowledge to know that there are 3 different types. Okay, and it's usually identified at birth, shortly after, if the parent did not know. And the diagnosis will be based on some of the physical characteristics that are commonly seen. So that includes low muscle tone, a single crease across the palm, and a single flattened facial profile or upward slant of the eyes. It's very common physical characteristics of children with Down syndrome. And they do confirm the diagnosis with a chromosome study. Okay, and it's a visual display of chromosomes grouped by their size. I had a picture of it, but I took it out to try to get us through the rest of our information. So some of the health issues, 40 to 60% of children with Downs will have a congenital heart defect. So it's important that the child have an echocardiogram on all newborns with Downs, and the reason that's super important because many of these procedures that can be addressed, they'll do it early while the child is still in the hospital and in the NICU after soon after birth. So it's important for them to do that quite early when they know the child has Downs, and children with Downs also have a higher incidence of infection, respiratory, vision, and hearing problems, as well as thyroid conditions. So um, there is a decreased lifespan for children with Down syndrome. The average age is 55 years, but many of them are living into their 60s and 70s. And a lot of that is due to uh, heart disease or some kind of comorbidity that develops over time um, with an adult with Down syndrome. So premature aging is seen in these individuals, and so they're basically their bodies are aging a lot faster than someone who does not have Downs. And there's big issue, which is C1, C2 instability. So that is the vertebrae, the first two vertebrae underneath the neck. And so because children with Downs are known to have lax ligaments, this instability can lead to a lot of neurological problem if you're not careful. And so we'll talk a little bit about that as we move on. So learning and development. So most children with Downs have mild to moderate impairments, but it's important to know that they are more like other children than they are different, just like we talked about. With CP, you should treat all of these children as you would a child that does not have the diagnosis in terms of engagement, in terms of fun, in terms of trying to figure out their communication style and what interests them. So early intervention services are typically provided shortly after birth, mainly because the diagnosis is clear. They know soon before you leave the hospital, the child has Downs. Therapy is already set up. And so these services usually include physical, occupational, and speech therapy. Most children attend their neighborhood schools and regular classes because many of these children are able to walk. And so they're able to engage in some of the typical education. They may be put in a special education class, but most often than not, they are in typical classrooms. And so some high school graduate Downs participate in post-secondary education. There are programs for adults with Down syndrome to allow them to enter the workforce or to find some kind of occupational training so that they can be integrated into the community. So these are the characteristics I was talking about. So very common, you'll see brachiocephaly, which is the back of the head flattening here on the top right. You'll see large fontanelles, which has to do with the size of the spaces between the brain plates. So you'll see larger spaces in between there. There's a flat contour face, underdeveloped facial bones and muscles. Usually you see a smaller nose. There's the simian crease that I was talking about with the crease along the middle of the hand, and slanted eyes with epicanthal folds, very common, as you can see here in that bottom picture there. And so there's also some other things that I don't have pictured here, but delayed formation of teeth. You may see a protruding abdomen, and there's a wide space between the first and second toe. And so us therapists who've had to splint children with Downs, it's actually a very common thing you'll see. So some of the other things you'll see in musculoskeletal problems are flat feet, which is pes planus, patellar instability. So I talked about the lax ligaments they have. So the kneecap is the patella, can go to the side. It may not stay in place because of the laxity there. I already talked about the risk of the C1, C2 subluxations, that's the atlantoaxial instability. Scoliosis, because many of these kids have low tone. So because of low tone, it's difficulty to hold their body against gravity as they get larger. So you may see some changes in the spine there. And hip dysplasia, which could occur because of the low tone and the ligament laxity, but also the lack of normal development of the hip and the hip joint. So back to the C1, C2 instability, you want to require or inquire about cervical x-rays when you're talking with or working with a child with with Down syndrome. This is important because over time, there still could be a risk of this C1, C2 instability. And so some of the things we're going to be watching as caregivers, as parents, as therapists, is for changes in motor function. You may see a change in their head posture. And if they're starting to tilt a certain way, there may be a slip that has occurred in that area. And this is very serious because you can have damage to the spinal cord. You can have changes in spasticity, and it can lead to, if it's not caught, it can lead to some kind of paralysis. So that's one of the red flags, things you want to just keep in your back pocket when working with a child with Down syndrome, or as a family member or caregiver to a child with Down syndrome. So you also want to keep in mind that maybe changes in bowel and bladder function, decreased diaper wetness or lack thereof can indicate neurogenic symptoms, right? There could be some change in bowel and bladder, and that may have to do with the impingement on the spinal cord, right? You may see a pain, limping, maybe some small fracture. Changes in appetite it can be indicative of metabolic changes, and changes in the walking pattern, spasticity can also lead you back to some kind of neurological impairment. So aging with Down syndrome, increased incidence of numerous age-related changes. So these are some of the typical age-related changes that we have to deal with. We've had a couple lectures on that this series. And so cardiovascular changes are most common, that can lead to a stroke, heart disease, heart failure, and some of the other things are hypothyroidism, which is common in Downs. But again, typically close to normal lifespan. Just have to stay on top of some of the comorbidities when working with this population into adulthood. So other thing that's very common is obesity in Down syndrome. So 78% male, 69% will have obesity, and it has to do with poor dietary habits, decreased metabolic rate, decreased exercise. Musculoskeletal changes will occur. Arthritis, hip dysplasia, osteoporosis, Alzheimer's. 75% of adults at the age of 60 will have some form of dementia and Alzheimer's. So if a child is an adult with Down syndrome, they'll be at risk of basically contracting this as well. And depression, especially depending on their ability to engage in the community. That's why engagement and peer participation is crucial. So once a young person graduates high school and they go into post-professional training with Downs, it's important to engage in some kind of, employment, or, getting engaged and being a productive member of society, if that is an option to your patient. Oh, and last but not least, we're talking about my babies with autism. Any questions about Downs? Okay, we'll circle back. So autism spectrum disorder. Now, autism is not necessarily classified as a motor disorder. It is a behavioral developmental disorder characterized clinically by delays and qualitative differences in communication and social interaction, as well as repetitive behaviors and restricted interests. So that's like the textbook definition, right? And so just to give you a little bit of history about autism, in 1940 was first documented, right, to those who could not relate to others. So one of the hallmark signs of autism was lack of eye contact, lack of engagement with family members or with the mother. And so there was so much historical just wrong definitions of why a child was not engaging with the parent, prehistoric definition. I'm not going to go down that road, but now we realize that there are some genetic or some, not even genetic, some metabolical changes that occur that kind of result in autism, and totally can be environmental, and we'll talk about that. But in 1950, the disorder was attributed to a lack of interaction with the mother, like I said, and then 1980s, infantile autism was categorized in the DSM-3. So we'll talk about that. That is the way that mental disorders are defined. And so that is the third version. We are now up to the fifth version. And in 1990, they included the spectrum of autism, which included Asperger's and pervasive personality disorder, and in addition to autism in the fourth version. And then now that we're in the DSM-5, it has redefined autism spectrum disorders and includes Asperger's and personality development disorder. So when we talk about the DSM, it's the Diagnostic and Statistical Manual of Mental Disorders, right? So that is something that is been put together, a product of more than 10 years of effort by hundreds of international experts in the aspects of mental health. And so when you look at neurodevelopmental disorders, it is a range of impairments in social interaction, verbal and nonverbal communication, as well as restrictions in behaviors and interests. So when we talk about ASD, the majority of children with autism spectrum disorder may have significant perceptual motor impairments that deserve assessment and intervention. So this is how it was defined in the DSM-4. They had them divided. There was autistic disorder, there was Asperger's, and there was pervasive developmental disorder. So when you talked about autism, it was impaired development of social interaction and communication, markedly restricted repertoire of interests and activities, and symptoms before the age of 3. Asperger's were delays in interaction, repetitive behaviors, and no delays in language, speech, and cognition. And PDD, it was the outlier. So when nothing fit in autism, pervasive developmental disorder was that last category where it was not specified, where you may see some ability to participate in routine activities, so they didn't qualify in autism. Asperger's, there may have been a delay in language and speech, and so there you go, you were kind of put into the pervasive developmental disorder box. So when we got to the DSM-5, now these three, autism, Asperger's, and PDD, were all put under autism spectrum disorder. And that's just important for anybody that has a family member diagnosed with autism. So you know that there's different categories in the way they may have been diagnosed before 2013 and the way they would be diagnosed now. And diagnosis is key because that's how health insurance and ICD-9 codes and all of that stuff is put together. So it's important to make sure that you're clear about diagnosis. And then there's another category that was created, which was social communication disorder, was limitation in social use of language, but it had the absence of restricted interest and repetitive behavior. So there are two different diagnoses there. So one could be autism and one could be social communication disorder, two different things under the DSM-5. And I say that because you may have been diagnosed with autism early on, but now because the child is demonstrating more engagement in some of their tasks, they may not be considered autism under the DSM-5. So it's important to know the difference. Okay, so there's levels of severity when we're talking about autism. There's 3 levels. So level 3 is the most involved, right? So when you're looking at this category, requires very substantial support, severe deficits in verbal, nonverbal social communication, severe impairment in functioning, very limited in initiation and social interaction. So decreased response to social overtures in the level 3 severity. Level 2 requires substantial support, marked deficits in verbal, nonverbal social communication skills, social impairment. And but with supports in place, you're seeing some progress, right? In level 2. Level 1 requires support, but with the supports in place, you're not seeing as much of the deficit, right? So that's how they would be classified if you were attempting to determine what their level of severity was. So they may appear to have some decreased social interaction. However, with some supports, they're able to engage and interact with peers. When I'm thinking of level 3, I've worked with children with severe autism spectrum disorder, where there is a huge behavioral component because the lack of communication or what they're feeling or where they're feeling accepted it's more of a challenge to overcome. So I will say this, as a therapist, it is our job. I hate the term non-compliant. I hate the term that when a child is not doing what you expect them to do. It is the caregiver's responsibility and the team to figure out how to engage this individual, how to pull out what they're attempting to communicate to us and to make them feel comfortable to a point where we can at least try to achieve functional goals, even as simple as, using the restroom, ADLs, which are activities of daily living. So it's important to not get so caught up on behavior and categorize it as non-compliant, it's really the onus on the professional to figure out how to communicate with this population. So with diagnosis, it usually diagnosed as early as 2, but typically around age 4. More severe cases are diagnosed earlier, right? You're starting to see things a lot sooner. And so mothers or anyone that is typically realized that there was something different about or unique about their child, they're the ones that will pick it up. Usually the pediatrician will not pick it up. And so it's important to encourage family members or anyone that may be having questions about their child's development, not to worry, but to go and inquire and say, well, I'm not seeing as much eye contact. I'm not seeing as many motor milestones. Like my other child was rolling by 5 months, 6 months, and now he's not doing that. So those things you feel comfortable enough to ask a family member or your doctor to inquire about whatever you may be seeing. But in terms of what's common, autism at 4, PDD by 4 years, 2 months, and Asperger's later in life, 6 years, 2 months. And parents, they'll notice the signs within the first year. Lack of eye contact, they're not hearing certain things, social communication breaches, and fine motor, lack of ability to hold on to little toys, puzzles, and things of that nature. All right, risk factors. The jury's still out with autism, but this is what the research has shown. Number 1, there is no link to vaccinations. I'm going to say this at least 10 times today because I know that is what people thought for a very long time, and that's not true. There is no link to any vaccinations for the child, for the mother. I'll talk about the study that went out that caused this mayhem back in 1998, but there is a weak link to genetic syndromes, about 10%. Identical twins and siblings have shown to have also have autism. So there's that genetic link, right? 46% of children with autism have average intellectual ability. So that's good news, right? So because there may be a social or communicative challenge, does not affect their cognitive capabilities in less close to half of the population has autism. And I don't know if you guys remember Rain Man, but Rain Man had autism. And, that was an example of a story of someone with really profound intellectual ability who had autism, right? And a communication disorder. So you want to make sure you keep that in mind. Children born to older parents have a higher risk of being diagnosed, and exposure to prescription medications. Again, I think each case is unique, but this is what the evidence has shown, and the references I have in the final slide. Again, vaccinations, there is no connection to autism and vaccinations. The study that was put out in 98 by Dr. Wakefield, there was so many problems that only had an N of 12 participants, financial conflicts, and he kind of led to the thought that mercury would develop and create this ileal lymphoid nodular hyperplasia in children with autism. First of all, mercury is no longer being used to bind vaccinations. And then 2, this study it was done incorrectly. It has since been retracted. And so again, I just say it, I know that's something that we've heard many times, but there is no link to vaccinations with autism. All right, so when looking at epidemiology, currently 1 in 54. So it was 1 in 59 in 2018. So I updated this weekend. And so so that is an increase, right? So it's up significantly from 1 in 166 in 2000. So there's many reasons for that. We may have more information, and we're diagnosing children with autism a lot earlier. It can be, like I said, increased sensitivity to diagnostic criteria. 83% of children have non-ASD developmental diagnoses. So they may not have autism, but they have some kind of social communication disorder. And it is the most commonly diagnosed pediatric condition in the United States. So autism, we have a lot more information about autism than we've had, and even some of as compared to some of the other disorders. So when looking at neuropathology, again, I'm not going to bore you with the science of it all, but they usually have typical head circumference at birth, but then it increases in the first 2 years. Again, these are just some findings from some of the research in autism. You're seeing overgrowth in the frontal and temporal lobes. This has to do with the brain structures, and there's an overconnection in short-range neurons, and which is thought to lead to poor integration of areas the ability to complete simple tasks is uninhibited. So it becomes more challenging, right? And this is the pathology that's correlated to what you may be seeing in a child with autism. And then they've also found impaired mirror neurons in the cortex. So that usually leads to the lack of imitation skills. So one of the tests that we use to kind of help identify some of these behaviors or the ability to imitate certain tasks. You may play Simon Says with a child when you're doing evaluation, or you may use a standardized assessment, and you may find difficulty with children with autism to actually do the same exact task. And what they've correlated that to was the impaired mirror neurons in the brain. So they need more task observation and reproduction than typically age matched peers. I just love the schematic. I got that from my colleague, Dr. Freeland, and I just thought it just really gives you a good idea of the multi-system involvement. And so when you look at this, you see the main core clinical features are social communication deficits, repetitive behaviors. So you may see a child repeat the same thing over and over with autism, or just the inability to engage or engage uniquely, right? And but that is tied to so many different things. The associated symptoms, they may not be sleeping well, mood, anxiety, hyperactivity, attention, tantrums, self-injury, aggression, language disability. I love how this is boxed in irritability. A lot of the negative behavioral things you may see with someone with autism, the tantrums, the aggression, the hitting, is due to irritability. And they're irritable maybe because they're misunderstood, maybe because they're not being able to communicate, or we haven't figured out the best way to engage them. So I just love the schematic, and really talks about what I'm going to focus on for the last few slides, which are the challenges with autism and some of the multi-layered, multi-system involvement. So we have the cognitive, social, communication, and sensory perceptual areas, the systems that are involved. So when I talk about cognitive, that's the ability to understand, the ability to determine or to think, right? To really understand what's happening in your day to day, to be able to synthesize information. So attention is a problem in children that have autism, and that would be considered a cognitive challenge, right? So they're preoccupied. There is difficulty shifting focus, lack or delay in responses to their name. So in executive functioning, under the cognitive capability, you may see difficulty inhibiting repetitive movements and inflexibility in patterns. So they're very rigid. A lot of children with autism, they do things a certain way all of the time. And that's because that's the level of comfort. But it is a challenge in executive functioning. It is a skill to be able to be flexible. So it is a higher level skill. But as we work with children with autism, you may see a speech therapist or occupational therapist attempt to encourage new patterns of thinking, new patterns of organizing their thoughts or materials or their desk, so that we create this layer of flexibility in their movement patterns or in their thought patterns. Social communication. So this has to do with difficulty developing social relationships. So they often want to play alone, lack of eye contact, language. So there's a lack of um, using different words, right? And echolalia is very common, which is the meaningless repetition of another person's spoken words as a symptom of a psychiatric disorder. So that is when the child is repeating the same thing, maybe something you've said, maybe something they've said, maybe something they've heard, and they go into a cycle of repeating that. And it is a symptom of the psychiatric component of autism. And then there's pragmatic language, just the ability uh, to have different words and be able to communicate effectively using different conversation skills. And then lastly, I'm going to talk a lot about this, which is sensory perceptual skills. I'll talk about the tactile system, vestibular, and that self stimulation that occurs in this population. So when talking about the tactile system, it's the largest sensory system, and it plays a major role in both physical and emotional behavior. So what you may see in children with autism is that there's a level of tactile defensiveness, and they have an aversion to certain stimuli. Okay, and so what we're looking for is to develop the ability for children to process this input, because it's important for neural organization. And so as the therapist, I want to incorporate appropriate activities to address both the tactile and proprioceptive systems. So proprioception is almost where they know where their body is in space, and this is something that is impaired in many children with autism. They really you may have heard that sensory seeker, or or sensory defensive. So when a child is really not sure where they are in space, they're thriving and searching for input to their joints and searching for opportunities to feel some level of a touch or a deep pressure. And so a lot of the times in therapy, we may use different swings or different weighted blankets to provide some of that input to remind them, this is where you are, this is where your hand is, this is where your elbow is. And it just has to do with the brain and the tactile system connecting and really trying to create those motor plans I talked about, right? Those motor maps. And so, but heavy touch, pressure are excellent activities for decreasing the tactile hypersensitivity and promoting proximal joint stability. So, in light touch or stimuli that tickle or irritate the child should be avoided. And so, you'll see that in children that may be really sensitive, right? Or they don't want a lot of touch. They may like the deep pressure, but if you start touching them very lightly, it makes them uncomfortable. So these are things to think about. You also want to avoid reject textured foods. And we talk about feeding, and all that stuff has to do with really the oral motor development. And so I tip my hat to the speech therapist. And hopefully next year we'll have a speech therapist to talk more about some of these things. But there are a lot of different responses to stimuli as a result of this system. So just keep in mind, if a child likes a certain food versus another food, it may be because they are finding an aversion to the texture. And we all have them. There's some things, I don't like mushrooms because I don't like the texture of mushrooms. So that's just me, right? So there's things that children with autism have experienced, but it's hard for them sometimes to communicate. So again, it's on us to figure it out. So the vestibular system. So the vestibular system is kind of what we use to know where we are. It's the use of our ear canals, where our head position is in space. We use our eyes to know where we are. So when you're trying to really address this in a child with autism, you want to think of ways to improve their balance, ways to help with eye contact and promote awareness. And we can use swings again, or barrels and scooter boards to try to get them in positions to move when they can feel safe enough to do that, so that we're stimulating this system and allowing them to have experiences in where their head is in different positions, again, adding to that flexibility of movement, or adding to their movement repertoire. So self-stimulation, you'll see this a lot with children with autism. They may use there's different ways to self-stimulate, but you may see mouthing of objects, the hand, spinning, head banging, arm flapping, teeth grinding, rocking, and self-biting. And so a lot of the time when you're seeing this self-stimulation, it is because they are attempting to feel some kind of sensory feeling, right? Or they are, it could be many reasons why they're doing the self-stimulation, but again, it is a result of the impairment in their tactile system and their proprioceptive system. And so you want to evaluate the sensory status, and you get with your OT and your speech therapist, the teacher, the entire team really can help get a great understanding on where do we go from here if someone has self-stimulating behaviors, and especially if they're dangerous to themselves or others. We really want to get the child in some kind of program so that we're feeding this desire for stimulation in a safe way. And so there's many different ways to do that, but it does fulfill basic sensory need. And so we need to figure out how, as the provider, we can either fulfill that need, replace it, or figure out what's overstimulating them. And they may just be reacting out of frustration and an inability to cope with some kind of sensory overload. And sometimes if I have a child that I'm treating with autism that's doing these behaviors, sometimes it's better to take them to a quiet space, a dark room, so that we can get them to calm their sensory system. Because if they're overloaded, trying to get 20 people to fix it in that moment is not the right thing to do. So just some things to think about. Okay, so when talking about the motor challenges with children with autism, communication and sensory impairments are the hallmark, but there may be some delays in motor skill. And so the large scale studies have demonstrated deficits in arm movements, bilateral coordination, gait and posture, and motor planning. What you also see on the physical component is stereotypical movement behaviors, repetitive behaviors. Again, some impulsive behaviors, resistance to change, excessive preoccupation with one activity. We have to play Candyland every day, all the time. You may see that, right? And I love Candyland, but sometimes you want to add another activity, right? So, and the gait may be ataxic. You may see that. So you may see a lack of arm swing. You often see some toe walking, idiopathic toe walking, which is usually a result of a child seeking some sensory behavior or seeking that input through his joints. And then you also will see some deficits in feedback and feed forward, understanding what if they fall because they did some activity, understanding that that is knowledge to not do the same thing again. So that's the feedback loop. But they may do the same thing over again and have the same results. And so again, that goes back to the motor planning that you'll see. Again, back to motor planning, you'll see a limitation there. Imitation, I already talked to you guys about, inability to copy a task. And you may see low tone. A lot of kids with autism may have some low tone. It all depends, but that's actually pretty common. And so this is, we're towards the end, exam and evaluation. Like I said, parents' perspective and interview are key. It's important to know what their preferences are, activities, textures, routines. Speaking as a physical therapist, I want to know about communication. I want to know what other treatment they're participating in. I want to know what their history is and their routines. And so you also want to find out how they interact with peers, especially family members and other children in the home. So you get an idea of what is their normal, because they may do something different at school and at home they're engaging, and because they're more comfortable, and just trying to maybe recreate that in a school setting may be helpful. Collaboration is key. You're going to work with the psychologists, special educators. Often in the school setting, you'll see the development of a behavioral plan. We'll talk about that. Speech and language pathologists, they are the communication experts, love them. And so I would talk with them about what's the best way to communicate with them in my therapy session. Occupational therapists, they usually address the sensory needs and the executive functioning as well. I've seen OTs really combine the two, and it's great. You may have heard of some of these standardized assessments if you know of a child with autism. If not, it wouldn't hurt. I mean, some of these are beneficial to have an assessment. The most common you may see, you see movement assessment battery for children can give you some information. The challenge with some of these standardized assessments is they're difficult and to complete, especially if it's a child you do not know. They're not going to want to do, most kids are not going to want to do something in your first meeting that requires them to jump up and down or do some kind of activity. So there's sometimes these assessments are hard, but there are some out there that a therapist can help you with. But if there is a decreased comprehension and cognition, you may find it more difficult to do these tasks. All right, so let's talk about the treatment options in autism. You may have heard of ABA, which is behavioral therapy. This is applied behavioral analysis, where they divide up each skill and of a task. And it's great because it actually compartmentalizes each area of the task, so you can focus on discrete trials. The instructions are very clear. There's a prompt that is allowed. You allow an opportunity for the child to respond. And if they give you the incorrect response, you start over, but you start over with a discrete task. You get immediate feedback. So ideally, you're training that feedback loop. But this is intense. So carryover at home will provide the best success, but this is very common in children with autism. You may see this to help develop training certain tasks. This is another behavioral therapy option, developmental individual difference relationship-based model. So this one promotes social interaction. And so this is the child leading. So very different from ABA. The child is leading the task, the approach. So the adult follows the child's lead. The child may instruct the adult may join the child's activity. The child sets the tone and directs interaction. Now, to be clear, you have to be very careful if you're going to pick something like this, depending on the child and their level of irritability or impulsivity. Of course, you don't want a situation where it can become a dangerous involvement with the child or others. But you observe as the adult, you approach, you follow the child's lead, the child expresses their ideas, and the whole goal is that the child feels understood. They feel warmth and connectedness, which is why I wanted to add it in here. Shout out to my speechies again. This is a picture exchange communication system. So they're often used with children that are non-verbal, meaning they do not speak verbally. And so you can exchange a picture with a desired object. The phases are a hand overhand assist with the picture selection, right? The self-initiated communication, the child picks the picture. Or what you may have I want at the top, and they'll pick from this choice right here. And then the multiple pictures to choose from, you help them maybe hand over hand pick place. If they have a motor challenge, put what they want in that little slot. And then as they grow, you add adjectives. You want to go beyond the basic needs. You want them to feel. You want to know what they like. You want to know what they see. So there is more research to be done in this area, but this is commonly used, and I have found some success with this. All right, so when I talk about PT, we're going to work on motor learning, object manipulation, playground, balance, safety awareness. I often push in to facilitate carryover if I'm in the classroom setting. So just so you guys know, before I started teaching full time, I was in the school setting. So worked at a school for special children with special needs. And I think, that gave such a great experience for me to learn how to really work in the classroom with teachers and collaborate. And so that is key for this population as well. This is a new thing that's out as well. Dietary restrictions, defeat autism now. Dan, there's some guides about gluten and dairy-free diets, some nutritional supplements, learning about hidden food allergy testing, detoxification of heavy material. There's no evidence yet to support this program, but there's a lot of buzz. So you want to look into it and share with your physician or your provider. I would encourage you. So this was a video of Kevin, and I think we're going to end with Kevin because we are out of time. And so let me grab that real quick. If there are any questions, feel free to unmute yourself, and you can ask if you want while we're here. All right, here we are. This is going to be our last video, or our last. I love this video because it shows this little guy how he behaviorally goes through his day, and I think it gives a nice little overview. So we'll go through that. So lack of eye contact there. You can see the toe walking there. Repetitive behaviors. He's self-stimulating right now. The head shaking. He likes sand. Or does he? I can't. Self-stimulating. He likes to watch the wheel go around. It's very enjoyable to him. He lines up his bolts very meticulously. This little guy likes structure, if you haven't noticed. like, now the one thing I liked about this part was that he's able to stack his blocks, showing you the fine motor capabilities, doing that really well, very meticulously. All right, that's what I wanted to share with you guys. So I want to just thank you guys all for joining. I'm going to stop the live so that we can have a couple of moments for questions. And thank you guys. We'll see you next weekend. We have another great series lecture on Saturday at 12 noon. And then we have our final event next Sunday, which is a health professional panel. So we hope to have an occupational therapist here, PTs, nurses, podiatrists, a couple people that tell all your young people, friends, your high schoolers, people that are maybe interested in going into the health field and not sure about what avenue to go into. And so we hope you guys can join us next week.